do we do to give the employees a plan that they actually wanted or could enjoy? And that takes a lot of partners working together to do things really quite differently. So a lot of things we did at municipal schools, Shelby County, MSSC we call it, we've done with other employer groups and in different kinds of situations. And so up here are really some of the partners that we've worked with in the different communities, this time mostly Northern Kentucky, Greater Cincinnati, on how to develop these health plans and what made them unique within the space of their industry. And within, just a couple quick notes, within local government in Greater Cincinnati, self-funding with third-party administration is the largest form of insuring themselves for groups of over 100. And for groups under 100, they're joining pools or collaborations, where they're collaborative efforts to come together for health care. And that's the way some of these things have been innovated within local government, and there's new ways to do it now for private employers as well. But having said that, I'm going to go down the aisle here and let each one of these individuals introduce themselves. Go ahead, Bill.
I'm Bill Banks. I work for St. Elizabeth Healthcare. We're the big hospital and physician group in Northern Kentucky and Southeast Indiana, about 5 hospitals and 900 physicians.
Alan Zanger, I'm with Pharmaceutical Horizons, and also today I'm going to represent Kurt Harden with MedBen, involved in prescription drug benefit administration.
I'm Lisa Boone with American Fidelity, and we're the ones with the boots on the ground to get to your people, to help get people enrolled and educated.
I'm Mike Molyneux. I'm the president of Symbol Health Solutions. We're a regional provider of on-site clinics, providing primary care, occupational health, and workers' comp solutions.
I'm Tom Weekman. I was Senior Director Administration at Sanitation District Number 1. That's the sewer business for the 3 Northern Kentucky counties. And I am retired, 5 years now.
Congrats.
Yeah, well, there's too many retired people on these panels these days. There's a problem we're having. I think we have to fix that in the future. Get a job. I've known Tom for too many years on these situations. And I need to ask a special request. I brought up the wrong piece of paper for my panel questions, so if someone from Sherrill Morgan could get me I got only part of panel 2 questions, so I need those brought up here. And in the meantime, I will just improvise.
Let's see whether you're really prepared.
See how really prepared or not? I slept in my cowboy boots, all right?
Just ask us what you have.
Well, I know. All right, great, thank you. Panel 2. That's the slideshow. Here's the rest of it. Okay, very good. See, they sent these out ahead of time so you can be ready. Oh, my goodness. All right, I believe the first question goes to Mr. Weekman in developing the plans. And Tom, a side note is that Tom was with SD1, a local government services organization that provides all the sanitation and all. So he's why, our community doesn't stink, in the past, for us as a sanitation district. So Tom, you were instrumental in kind of reinventing your health plan. What was the one problem you were trying to solve? Was employee dissatisfaction or some other driving force?
We were, the question about employee dissatisfaction, we didn't face that. The challenge or problem that we faced from maybe the late 90s on is, how do you deal with what we still talk about today, the rising cost of care? Probably in the mid 90s when I was starting, the benefit costs for medical benefit costs were somewhere down here on our budget line, right below the cost of manhole covers and sewer lids. But when the cost of the medical care started to become more than the cost of a sewer manhole lid, then it started getting our attention, and we realized we had to start thinking a little bit more ahead. We had to be innovative, maybe, and I didn't realize we were innovative. We were just trying to survive and create or have a package that our employees would appreciate. Employees are pretty easy, I think, to understand. They want the best care they can possibly get for the least amount of money they can possibly pay. And that's generally in conflict with the employer who's trying to provide a benefit and keep operating costs down. So you're pushing and shoving. So along the way, you have to get creative. But more importantly, I think as I was sitting here, I've been here about 2 hours now, and I've been retired for 5 years, and I've just realized I'm 25 years behind the time, listening to what folks are talking about. We were pretty basic. Back in the late 90s, early 2000s, we decided that the self-funded path was where we needed to be. We felt we needed to be able to control our benefit package, control our cost better, to manage the networks. And to do that, we realized very quickly it would take working with people a lot smarter than we were. So we engaged Mark, Sherrill Morgan, he engaged other folks and some experts along the way that were truly valuable in what we've done or were able to do at SD1. The other thing we knew early on was to engage employees in the business. You don't show up once a year and say, here's your new premium. You show up almost every day of the year explaining medical cost, explaining what's happening, explaining what's changing, explaining why the costs are going up. We held out as long as we could with a zero premium for our employees, but in the, I don't know, 2010-ish time frame, we had to implement employee premiums, so they were dissatisfied. but they knew why. And that became the key, I think, to us, is if folks knew why things were happening to them, they appreciated that better. They didn't understand reference-based pricing. They didn't understand self-funded necessarily, but they understood what cost meant and what that eventually meant to them. So that got us on the path then of getting our employees very wrapped as tight as we could with Mark and his team's help, getting them wrapped into their care. We felt that they had to become very, very involved intimately with what they were doing with their doctors, seeking their care. So that became a big part of our plan, our approach. And one of the things that eventually led to was the installation of a clinic at SD1. But I remember in early 2000, Mark and I were innovators then. I said, Mark, I can hire an engineer, I can hire a lawyer, why can't I hire a doctor? Why can't I put somebody in my shop and put them in an office to let our employees go and visit them like they would a lawyer? What's holding us back? Those were good conversations, but we didn't come up with an answer until maybe 2011, 2012. That was kind of our approach: involve folks, do the best we can to manage our care, and involve experts who knew a whole lot more than we did about this business.
Thank you, Tom. In fact, you gave a good example. I think one of the things that was innovative is you're one of the early adopters, or tried to be one of the early adopters, before they even really were prominent in the market space, was the clinics. In fact, we'll go a little bit out of order since you referenced that, and we'll go to Mr. Molyneux. And Mike, I know the question that you're prepared for is preventative care and what that means, but talk just a little bit, though, about what's it like to be brought into an employer and be asked to be their primary care physician? What's the hurdles you face with those employees, not only getting them to come into the facility, but then being able to proactively take care of their care ongoing?
Well, this would be an impromptu answer
Yeah.
for your impromptu question. But, it starts off, it's always, it seems like, at least these days, it's a competitive process, and there's an RFP put out. And you answer these basic questions, and they get repeated over and over again. Now with AI, it's almost like, let AI fill out the questions, fill out the answers for you, and then give them, your model. But to do a clinic, the reason for a clinic is a cost lever, lowering lever. We start by selling the employer the idea that if we intervene, proactively intervene with patients, with your employees, usually, via an incentivized program. To back up for a second, we actually started as a wellness company back in 2005. wellness and coaching. My background, actually, I'm a physical therapist by training many years ago. Don't come see me now. I'm rusty and I would hurt you. Anyways, and so we eventually found that we could have a greater impact by offering acute primary care on site. We start by selling them on the fact that we're going to prevent downstream cost. And we do that to start with by mass biometric screening of the entire employee base. We're used to having anywhere between 95 and almost 100% of employees participate in this biometric screen. And we take baseline information and take the same information every year, year over year, and we follow those people who are still there, those employees that stay year after year in a cohort. But then what we do is we, at the end of this session, we give them the results right then and there, okay? And then we'll have a results coach, which would be maybe one of our health coaches. So where your employer is also offering an incentive if you will participate in the wellness program. It could be just a health coaching program, one-on-one, face-to-face, nothing virtual. It could be something, a point-based thing, with a point-based program where you can, based on participation, not necessarily on results. That gets you into another category. But by using that biometric data and taking claims data from the plan, okay? So when the person comes to one of our clinics, okay, I mean, people do like free, and so all of our clinics, there are no copays for the visit or for the prescription meds that we would dispense. So we ask the employer to give us their claims data. So when that person comes to see us for a cold or sinusitis or ingrown toenail or whatever they might come in for episodic care, we take that as an opportunity to engage with that employee and get them to come back and see us. When you feel better, there's these things here that we see that you may be missing out on in terms of your care. How do we get that information? So through claims data analytics these days, when that person that employee walks into the clinic, it doesn't have to be the employee, it could be the spouse or the dependent as well. We pretty much have a full health profile of that person. We tie their name to their ICD-10 code, to their diagnosis. We tie those diagnoses to the standards of care put out by HEDIS, or the U.S. Task Force on Preventive Medicine, and others, American Cancer Association, American Heart Association. And then we look for the CPT codes, like, did you have this procedure done? Or we look for the NDC code. Are you on this medication, which is tied to the standard, which is tied to the patient? We look for the LOINC codes for the labs. Have you had your A1C done? These sort of things. So we engage with that patient. But when they finish that biometric screen on that first day when we get there, we tell them, well, your employer is also offering you X if you will participate in the wellness program. And I'm sorry to say it really does require an incentive. I've been doing this for a long, long time. And it's like, no copays, you're very likely to take that medicine if there's no copay. If the clinic's there, they can come, on company time. It doesn't cost them anything. A 50-year-old male with, hyperlipidemia, hypertension, and maybe a A1C of 5.7 that you want to prevent from having a disaster later. They'll come if it's free, and they can come on the clock. So now everybody participates in the wellness program. Everybody participates in the biometric screen because it's there. We usually do it at the benefit fair, but not everybody in that first year is going to use the clinic. But they're being incentivized to participate in the wellness program. So we'll probably see anywhere between 65 and 80% of all employees in that first year in the wellness program. We use those same data analytics with our health coaches to make that first interaction and saying, hey, look, these are some of the gaps in care that you have. We can provide those here at the clinic, or you should go see your own primary care doctor, but we need to do that. So implementing health strategies, as well as giving, acute, episodic primary care, but probably when we start, maybe 70% of what we see is acute episodic care. With a 3 or 4 or 5 year mature clinic, it's probably 70% preventive care, maintenance care, and 30% acute episodic care. So on-site clinics used with definitive, proactive health prevention strategies is an excellent way to help keep your costs down. But it's a big old ship, It's a big ship, and you're not going to turn it. It takes a while to turn that big ship, and you got to stick with it. You can't have the benefits broker. They're getting pressure because you've been there for 2 years and their health care costs have not come down by 20%. And we're not sure we're seeing the benefit. Well, you're not going to see the benefit immediately. It might take 3 to 5 years before you do see these benefits, and this is how you measure it, and then I'll stop. You measure the efficacy of your on-site clinic by let's take a diagnosis, let's say diabetes because it's popular, particularly where I come from, or hypertension or obesity. And what you do is you take those patients who are engaged in the clinic, which includes the wellness program, those who are engaged in the clinic, the overall cost of their care for diabetes in a year versus those who are not engaged. So those who are engaged, the total cost includes not only what they spent at the clinic, but also what they've spent through the plan, okay? And then you compare that to those who only had expenses in the plan. And you will undoubtedly, with an effective program, you will undoubtedly see a significant difference, anywhere between 20, 30, 35% difference in the cost of those who are engaged in the clinic and wellness programs.
Thank you, Mike. If you're from my generation and you sat and watched TV with your mother sometimes, and she watched a lot of soap operas, every once in a while you just hear this really low voice come on and say, playing the part of Paul is actor John J. Smith. Well, playing the part of Kurt Hardin today for us is Mr. Alan Zanger. Can we like to ask Mr. Kurt Hardin, Alan, a question? And that is, MedBen has been a cutting-edge innovator, implementing innovative programs for many years. And what has been the hurdles and the examples of what can be done and the struggles to get it done?
Thanks, Mark. It's good to be with all of you again today. So MedBen has been a client of mine for over 25 years. Been working on a number of things that I think have paid dividends for groups. So the litany of things are things that you're probably already familiar with in a drug benefit program, things like drug formularies, copay designs. And some of those have taken on increasing importance in some respects, but there have been effective strategies to try to minimize those by outside forces. But MedBen's been an early adopter of many of the ideas that came about. With Tom here, I think with Sanitation District, I think they were one of the first groups where we talked about a member first copay, where the member paid the first amount of a prescription claim and then the plan picked up the remainder of that, all designed to try to encourage the members to shift towards generic dispensing. So the idea of what works in a drug benefit plan from a cost standpoint is always about trying to maximize that generic dispensing within your plan. And there have been lots of different copay designs that have been put into place over the decades, literally. And drug formularies have tied into that. Preferred brand drugs, But the idea of non-preferred brand drugs tied with then at the end of that drug company discounts, rebates that are part of that. The philosophy that MedBen has always used with that, and that basically I encouraged, was the idea that you always want to try to, within a drug class, have members used first that lowest cost option. In today's world, and back 25 years ago, that was a generic medicine, still is, still will be. We've added a little twist into that, which are the biosimilars for specialty drugs like Humira and Stelara. But the idea of all of that is to get to that lowest cost option that's going to be effective for a patient. We want the drug benefit to be a quality benefit, for sure, but there's a lot of cost pressures that come into that are from external sources, for sure. I think the biggest of those right now would be the drug companies. I was, in some of the background work that I did for this, since 1984, which, by the way, was when I first started working in managed care, to 2025, the producer price index for drugs and medicines in the United States has gone up 582% from the baseline. For other manufacturing businesses, all other manufacturing businesses in the United States, that increase is 250%. So the drug companies are basically doubling their prices over the same interval where other manufactured goods are today. The top five, let's see, I think I'm not going to get this right. The top five drug companies in the United States today have doubled their profits in the past 10 years. I don't think I have that here, but drug companies have done very, very well, and often at the expense of your drug benefit plan. So it's really important to recognize their outsized influence from a pricing standpoint. And I've been a pharmacist, or I've been involved in pharmacies for over 50 years now, and I got to tell you that in those 50 years, despite all of the talk that happens publicly about trying to figure out a way to get manufacturers to control their prices, it hasn't happened. So the other piece that's happening with drug companies is that they are highly effective marketers. And you know who their target market is right now? Your employees and their dependents. They have ceased really effectively marketing to providers anymore, and that's because they found out that direct-to-consumer advertising and their copay assistance programs far outweigh anything else they can do to influence product selection. Prescribing by a physician or a nurse practitioner or a physician assistant. And they are highly effective. It works. They wouldn't do it if it didn't work. So those are big threat issues to the design strategies that are out there. So I think one of the things that was mentioned earlier is communication is huge when it comes to between the employer and their employees about what options are. And I know that when we're talking about what are the future innovations that are happening out there, I know that MedBen is piloting with, I think, one of the vendors, HealthJoy, back here today, working on kind of an initial generative AI tool that employees can use that will help them identify or navigate the pathway of the complexities that are out there. I think part of the question that Mark was asking is, what are the administrative hurdles that exist out there? Well, frankly, communication is a big part of it, and the complexity of what we're talking about here. Put this in perspective for you. When I was first licensed as a pharmacist in 1979, there were no ACE inhibitors on the market for hypertension or heart disease. None. Today, they're all available generically, and there are 8 of them at least, maybe more than that. So what's happened over my life as a pharmacist is the complexity of these things has just exploded. I did my first formulary, and the two hot drugs at the time, Tagamet and Zantac. We had contracting fights over Tagamet and Zantac. They're now known as cimetidine and, well, actually Zantac is no longer available, but famotidine was Merck's product in that same H2 receptor antagonist class. You won't hear about them today because everybody talks about they talk about Prilosec and Nexium. Those are the replacement drugs that came along after that. So we are dealing with an orders of magnitude more complex environment when it comes to prescription drugs. Communication about working with patients to identify effective low-cost options before you get to higher-cost options is really critical, and tools for that I think will be coming about. But so I think that what we've always worked towards is trying to provide a quality, affordable benefit with prescription drug system, knowing that there are multiple factors that are involved in that. I'd probably have gone way over time on that, but you give me. Well, part of it is this administrative. What are the administrative barriers? And frankly, when I started working in a drugstore, we used to tear apart paper claims to submit to Blue Cross and Blue Shield and other insurers, and we'd send them off, and a month later we'd get back a check with the listing of all those claims. That doesn't happen anymore, right? We do everything electronically. I mean, a patient walks into a pharmacy and the prescription claim is captured, and if it's clean, it's processed immediately, and the patient walks out with their medicine for a copay, out of pocket. It could be that they're also told that it's going to take a prior authorization, right? So that starts a process that is administratively more cumbersome than simply the transaction of processing a claim. So we're really good at processing claims. When we put impediments, if you will, in the way of that first claim being processed, that's when things start to slow down. Now, I think that as I've talked with organizations that are involved in processing of claims and work in the area of prior authorization, I think that there's going to be some AI applications that will come in to work on that, but we're all on the front edge of that AI piece there. So there's progress that's been made. There's utilities that are out there that members can use to kind of help them look at what's available to them from a prescription standpoint, but recognize that there's a lot of influences that are happening out there that are promoting the use of medicines that for most patients are going to be second or third, maybe fourth level choices within the armamentarium.
Great. Thank you, Alan. Bill Banks is one of our partners with St. Elizabeth, and working with them has been a really unique experience because even our clinics now, you would think that those work against a provider organization, but now our clinics are partnered that all of our services are referred to St. Elizabeth hospitals because they're the ones that are giving us the opportunity to not only expand the ability for care, but also to reduce our costs. So Bill is one of the early adopters of direct contracting with employer groups and what that meant, and partnering with self-funded health plans outside of the Buca universe. But Bill, could you talk about why that's been beneficial? Why would St. Elizabeth ever want to do that kind of thing?
Sure. It's not because we make a lot of money at it. I'll describe that. 2010 was probably the first time we did something like that, and we tried it with our own population, sort of a narrow network approach to telling our associates, if you take this HMO and only use St. Elizabeth, then we'll knock down some dollars out of your contribution, et cetera. We worked with Humana at the time, and our intention, I think going back to our earlier discussion, it was very important for us at the time that Humana offered this out to the community as writ large, because we didn't want to just do it for ourselves. We really do consider ourselves, we're a Catholic hospital if you don't know, and we consider ourselves pretty much a public utility, very much like a water district or sanitation district. We're here for the good of the people of Northern Kentucky. And that's really important about how we think about these kind of projects. I'm not just here to make a lot of money, I'm here to balance a budget. That's absolutely true. I'm the lead economist for the system, and it's my job to make money, but we have a mission to perform. So the direct answer to why would we do that is mostly because we had employers asking us to do it. the whole reason we have a business health division. We will do EAP programs, we'll do flu shots for you, we'll do on-site clinics if you want, or we'll work with the on-site clinics that are present in the market. We don't really care. We want to deliver what the community wants. So that should be understood as the impetus behind anything we do out there. So the last 15 years, I've been on a journey to do a lot of direct contracting. We probably peaked at about 2015, 2016. We had 50 or 60 of these that I had signed a lot of contracts with a lot of employers. Over that time, though, to extend that, we're now back down to a place where we only have one. I've got one contract, and it's actually with EAS, Employer Advisory Services. We got to the place where we decided there's just not enough demand in the market for this thing, and it's complicated to administer. Let me reach out and grab Terry and EAS and say, you guys keep the one contract, and we'll send anybody that wants a direct contract your way. That's how we've approached the market. But if a huge demand for the whole thing kind of blossomed overnight, we'd react to that.
Get ready, it's going to blossom.
Let's go. Yeah, I mean, the hospitals are big, huge. We're like a $2+ billion enterprise at this point, so we've got a lot of plates spinning and a lot of things to juggle. But the primary mission for our hospital is take care of the people in our market, and I extend that out to the employers in our market in a very real sense. So you'll see me doing a lot of things. We've changed our charging structure so that we don't charge outlier claims anymore out of our hospital. Little things like that were done strictly for the benefit of the small employer community.
Yeah, I think one of the interesting things that Bill said when we first started the relationship is that first was primarily for local government, but now a lot of big private industry uses it as well, and the direct contracting. Bill said, you know what, we're not going anywhere, and neither are they. So let's do the things we can do to build a close relationship with one another and benefit one another. So that's been a great partnership with St. Elizabeth for those purposes. And now we've had all these different benefit programs described and quite diverse, and then part of the communication problem is the communication problem. So Lisa with American Fidelity helps us enroll most of our groups, and they do it in a unique fashion. And I want you to talk about how you help assist in the communication of all these benefits along with what you do.
Absolutely, thank you. You've teed that up beautifully, all the communication. So we do know that is very key. You spend a large amount of your budget on benefits, retirement, all the benefits. We find it's usually 25 to 30% of your budget, and for employees as well. And employees want to understand their benefits. They want to be empowered. We also know that they don't go dig for the information themselves, and a 5-page summary plan description is never going to be read. 5 bullets probably aren't going to be read, right? We also know that the more complicated a topic is, the more employees want a one-on-one interaction. And when we're talking benefits, you really can't get any more complicated than that. And then we add Section 125 to it, flexible spending accounts or health savings accounts, and now we're talking about benefits and taxes. So very complicated. So we know in the surveys that employees do want one-on-one direct communication when it comes to their benefits. They want to be able to ask questions in a private setting. We also know that 85% of employees want options. They want to be able to customize solutions for them. And we also know that when it comes to taxes and benefits, people need it in bite-sized pieces. They need it throughout the year, which I know is something Tom was talking about. And they need to hear it about 5 to 7 times before it sinks in. They also need it in a variety of ways. We still have our paper people, we have our video people and our phone people, right? So we have to be able to do it through a variety of ways, and that's where American Fidelity comes in. We're in 48 states. We work with employers of all sizes, and you can imagine the different plans and payroll companies and all kinds of things that we work with, which allows us to customize a solution for you and your employees. And that's where we partner with you to come up with that solution. We have online platforms and then the variety of ways to communicate with people. But we have the bandwidth and the employees. There's over 500 of us across the nation that will sit one-on-one with your employees. With that, we are helping enroll in what we call their core benefits, the health, dental, vision, those kinds of things, group life. But then we offer supplemental benefits to enhance that. to allow employees to customize a solution for them and get something very special for them. We know what a 30-year-old needs is very different than what a 50-year-old needs. And you can't always customize those core benefits. You can't offer 4 dental plans, right? So we become that customized solution for you. We can offer a variety of disability plans with none of our benefits have any kind of participation requirements. If one person wants something, we're good with that. We have pooled statewide plans, so we're not quoting based on your size and your census data. We own the pool, we make money off the pool. We've never had rate increases where rates don't go up as you get older. And all of our benefits can go with your employees when they leave or retire. So these are really great things that your employees love, to be able to customize a solution around what you're providing. And then during that one-on-one communication, we can explain whatever program you're wanting to highlight, health, your pharmacy program, your wellness programs, whatever that may be, getting health declination forms. We can help you with that. We also can do dependent verification reviews. That's been another thing that we've been doing for a lot of our employers as well. So we round out the partnership, and we're really proud to work with Sherrill Morgan and most of you. So if we're not working with you, let me know. We're right over there. And we are very excited about the baseball game tonight, too.
You know, it's Memphis uses, Shelby County uses American Fidelity, and when you talk about complexity of a plan, they're able to communicate it all because they've got, you know, some of our first early adopters of brick and mortar pharmacy, where we want your clinic prescribing to their pharmacy, and that clinic prescribing to our direct contract with the providers there, to where we want the formulary that the clinic and the PBM and the administrator all realize are a coordinated formulary, even in that situation, because normally a clinic and an independent pharmacy and or employer-owned pharmacy and a PBM's formularies are not connected. So everybody said, well, this is a great idea. Let's put these things in. But the complication was they all had their own formularies they had adopted, and then there wasn't a normal method to communicate that formulary between them. So in innovation, you sometimes come across problems that you didn't anticipate. So it's been really interesting in finding ways that now we can integrate between the formulary of the clinic, to the formulary of the pharmacy, to the formulary of the health plan, so that we're one unified body having that happen. And so communication of benefits gets, and what they've been able to do in Memphis for us, American Fidelity, gets down to the nitty-gritty of how your prescribing habits are used. You know, how are you operating your health plan from that aspect? Because there's some other innovative things we'll talk briefly about here that maybe we'll ask Alan to make comment on again. But one of the things a lot of you have done is gotten rid of your specialty drug programs to where you act like you don't cover specialty drug, but you really do, in order that we can obtain some of the benefits of the better manufacturer coupons and patient assistance programs. But what has to go into that? And then the employee still gets the drug, even if those don't come in, and it's paid for by an independent HRA rather than through the health plan. And the plan saved millions of dollars because of that, and the member still gets the drug. But Alan, what's some of the things that have to be coordinated, has to happen for that to work right?
It takes the patient with a prescription at the pharmacy where the process starts, and if that is a denial as a plan exclusion, then there's the path to, under the copay assistance programs would be for the physician and the patient to then contact the assistance program administrator. That may be a standalone organization. It may be an organization created or supporting the actual manufacturer. They will research the benefit, determine and validate, in fact, that it's excluded. And then they have to determine where the money's going to come from to pay for the drug in that case. Pretty convoluted. And it's not exactly linear in point A to B to C to D. And it's because the payer of last resort in that scenario would be the drug company at the end of the day. So they're going to do their best to try to find a foundation or some other source of money that will help defray the drug company's loss, if you want to think of it that way. They just don't reap the full selling price of their drug in that situation. So it's a product of it's a product of our system, I guess is the best way to say that. Does that help?
Yeah, it does. Just that some of you done that and it's worked smoothly for you. But I think it was interesting to see from, a pharmacist's point of view, understanding how really the sausage is made isn't always as pretty as what it tastes like once you get it. So it's a really beautiful benefit program to put in, because remember, it's getting it for free. But you can see behind the scenes, it causes some angst, where up front you're just saying, well, this is a great program. Real quick, Tom, you with drugs, your organization put in a zero copay for a number of drugs, not just over the counter. Why did you do that?
We did that? Why would we do that? Well, why would we do it? Well, we received good advice is more than likely why we did it, but we just wanted to have an opportunity for our folks to, I guess, we wanted to move them to the lower cost generic products that saved our plan money, which is, that's our focus. That's what the company's trying to do, so we can better manage our cost, but still provide a good product, a good benefit for our employees. I mean, the medical benefit is simply there so we can attract and recruit and retain good employees. If we were recruiting and retaining and had the best people working for us, we may not need to offer a medical benefit anyway. But the benefit helps us accomplish what we're trying to do as a company, moving them into a plan or a program that provides good care, good coverage, good product, good benefit, and then be able to do it at a zero cost to encourage that. That was our thinking at the time, I suspect. But
And it worked, and that's why.
And it worked.
Last question from the panel, then we'll take questions. Mike, you dispense drugs in your clinics for free. Why do you do that?
Because they're a fraction of the cost that it would cost through the plan.
Yeah.
And that's not really the answer. The answer is, I think our friends at AS Meds told me one time not long ago that 37% of first-time prescriptions never get filled. The compliancy. If we have the drug, if the patient comes in, gets seen by the provider, this is what you have. This is the prescription I'm going to write for you. And by the way, just walk next door or walk to the other room actually, and we'll dispense that medication for you. So the compliancy is really what you're looking for, okay? Because the compliancy is what's going to eventually drive down costs. But why do we dispense in the clinic? Now, we don't dispense any specialty meds unless we're specifically asked. It's all generics and just a few brands, and those are mainly the insulins and the steroid inhalers. And why is that? Well, this is our customer wants, they want us to drive the generic formulations, but that doesn't mean, since we don't dispense them, that doesn't mean our providers don't write them. They write prescriptions for Ozempic. So the provider, one thing we don't do, we never get in between management and the provider and what that provider does, how that person practices medicine. There's no interference there. And so it's really up to the plan, if you're having problems with Ozempic and Mounjaro and, Solera and keep on going down the list, that's for the plan to decide. Okay, it's not for our providers to decide. But the main reason that we dispensing the clinics is for the compliancy and the fact that, you know, prepackaged generic medications are what we dispense, and they're very inexpensive.
When we have Mike in the dispensing a drug, you're removing so many middlemen that a lot of the generic drugs, if you actually just paid the price of the drug, we're talking about pennies or dollars. But by the time you pay the $1 or so for the drug and you move the drug, I'm not sure what the average is now, but you're adding on top of that 50 cents or $1 for the drug about $19.50 just to get it moved to the member. Way more than what the cost of the drug is. So anytime you can cut out all those people in the middle, then all of a sudden you're buying the drug for a lot less. So therefore, we can give it away to have them get their drug through that vehicle and all. Any questions out there for this panel? Yes.
So I'm in startups in Silicon Valley. So I've seen over a half dozen different prior automation tools out there. So I was curious about what some of the systemic, I guess, barriers are, why these haven't been adopted more widely.
I'm sorry, can you say the first part again? Prior authorizations? Yeah, go ahead.
You say a half a dozen startups that are launching these?
Some at like a Series B, like I would say 10 plus, lots of companies that are in the space, but it sounds like they haven't reached you yet, so.
No, I think there's a lot of evaluation happening to build AI support into the prior authorization process. I think one of the challenges, one of the comments that I didn't make was, I'm not sure that long term that prior authorization will be effective as a cost management tool in a health plan. And the reason why I say that is that if a patient, this is one of the challenges of prior authorization, is that if the patient meets the criteria established pretty much in the healthcare community, you're going to have that claim. You're going to have that claim. And so if a patient meets the criteria for use of 2 oral medicines for a cancer drug these days, that's going to be at least a $200,000 a year hit to your plan. So I'm not, I've done prior authorizations for 25 years. Since Enbrel came to the market as the first specialty drug, we've been working on prior authorizations for these. And prior authorization initially was pretty effective, but as I'm approaching sort of the end of my prior authorization work time, I see it as more of a hurdle than anything else, a speed bump, if you want to call it that. What really causes a pause and what protects or insulates the plan is the word exclusion. That's excluding the drug, and that then puts the onus on the member and the provider to then make a clinical case to the plan for that medicine. I've done, over the past several years, I've been very active in the appeal review process. Most of those appeal reviews have come with GLP-1 agonists, and frankly, it's pretty easy in many cases to cut and dry on that from a recommendation to the group. What's going to be more challenging, frankly, are the clinically more complicated cases. How do you handle a patient with Duchenne's muscular dystrophy? What is effective and what isn't? Does the patient meet the criteria for use or not? But if the plan excludes the drug, then that sets up a whole nother cascade of, do they meet the criteria for use? Is there another payer of majority in that or not? So I think, circling back, I think generative AI will be a help in that process. I'm not sure what I see, I'm not sure what the value, long-term value is of prior authorization.
Because the drug's still going to cost a lot of money. It's really the bottom line. And there's going to be more substances treating the same diseases coming out because there's money in it. Any other questions?
Just one more quick follow-up to make sure that I fully understood. So if, thinking about the long term, prior authorization is going to become more and more just a small speed bump in the whole process, it sounds like you think that a lot more of the issues are going to be upstream and, the formulary or, the settlement between those two, or even coming up with the monographs themselves. Am I understanding correctly?
My preferred model, frankly, would be for employers, in particular, to think of an insured risk pool for catastrophic clinical conditions. I'm gonna use this with some trepidation, but this is a FEMA-like model. Individual employers, even large employers, don't have the financial bandwidth to deal with the looming cost of technology that's coming down the pike. I think that the long-term strategy is to create criteria for classifying patients as clinical catastrophes and then treating them as such from an underwriting standpoint, from a management standpoint. Bring the clinical experts in for that, make a determination where they can sit down with the patient and their families to explain what the realities are of the technologies that are available and what the options, what the realistic outcomes are going to be for that. That's what the past 10 years have been leading me to, and that's a preservation piece for the employer market today. Get involved, keep the employers involved in chronic cases, but in the catastrophic cases, that's a much bigger nut to crack.
There's some new organizations coming out too that evaluate the substances based on clinical data. For instance, we've got 5 different drugs that cover one condition, and a new one comes out, and the new one that comes out is probably the most expensive one. So it evaluates it to say, okay, the drug created 20 years ago, the drug created 5 years ago, 2 years ago, this year, setting aside first their cost, which one has the best efficacy. What we often find is that efficacy is sometimes better with an older substance, a cheaper substance, than the newest substance. Because remember, the criteria for approving a new drug is that it's better than placebo. That's the criteria that the FDA uses, that it's better than placebo. So the newest drug doesn't necessarily mean the best, it just means it was better than placebo. So go back then to looking at all those different drugs on an efficacy basis, and there are occasions where the most expensive drug might be a little bit more efficacious, but the other drug is cheaper, is just about as efficacious. Why go to the more expensive one? And there are a couple of instances, I can only think of one really that have been shown, the most expensive drug was really the right drug to use. And we're just going to have to decide to cover it or not. But that's one way of looking at the drug industry, but the formularies are even controlled by the insurance companies, and what their formularies are, that's what the retailer will carry. So then when you prescribe something and the pharmacy doesn't have it in stock, it's not because they had a bad order day, it's because we normally don't carry that because nobody buys it.
So keep this in perspective. As I've been analyzing group spend within the prescription benefit, 50% of the claims are for the specialty drugs, which is 50% of the dollars spent is specialty drugs, and that's that's less than 5% of your claims for most groups. And that number is going to do nothing but increase. Nothing but increase. So you have a small subset of patients consuming huge components of this benefit program, and frankly, I don't see it as sustainable. It's not sustainable. There has to be another mechanism by which to deal with this. Again, I've seen prior authorizations where patients are on two medications, outpatient oral medications for cancer chemotherapies that are $250, $1,000 each. And they meet criteria for use. A client a couple years ago came to me and said, we're really worried about these, they called them SAD drugs, scary blank drugs. So you can put in the A word there if you'd like to choose that. But they said, Alan, we gotta do something about this. You gotta help us with this. They said, we need you to develop a carve-out list of drugs for anything that's over $150,000 a year. They have it. It's in their plan. Covers both infusion medicines as well as outpatient prescription medicines. It's part of their plan for groups that they want to adopt that.
Yeah, yeah.
It's a hard place to be. It's just a hard place to be. Yeah.
So then, quickly, because we're about to close here, then, the industry, pharmacy industry, doesn't make money if you change the model. Okay? You change the model, and that's why you don't hear other models talked about. Why you don't hear how dispensing, or even, employer-owned based brick and mortar. But beyond that, you don't hear the terms own use. You don't hear the terms 340B. And these are things, or you don't hear acquisition cost pricing, because there's no money in it. But that doesn't mean you can't be using them. So they're in international sourcing's in limbo at the moment, but still that's another source that you never heard much about. That's probably the most well-known one. But our health plans are now beginning to use those that qualify for own use, those that qualify for 340B. Again, those are not the end. That's not going to end the problem, but they're short-term patches to the dam that as it moves forward. Right?
And there are groups effectively doing that.
Effectively doing that, correct.
Effectively doing that
Yes.
and using those.
When one of ours is now effectively doing the 340B program through their brick and mortar that's qualified as a 340B facility. So thank you all very much, and we'll put a QR code back up there again for the app, and appreciate it. Oh, thank you. Thank you, guys.